I've been rejoined by my co-host. um, Thank you so much, Jenny. It's so lovely to have you here. Um, I will can't wait to introduce our next speaker, Jennie Joseph. Will you be sharing your slides, Jenny?
I'm ready to go.
Okay, great. So, Jennie Joseph is a British trained midwife who fights to ensure every person has their healthiest possible pregnancy, birth, and postnatal experience with dignity and support. Jennie created the JJ Way, which is an evidence-based maternity care model, delivering readily accessible, patient-centered, culturally congruent care to women in areas that she terms maternal toxic zones. Her focus and drive is to ensure that Black women and other marginalized people remain safe and empowered inside broken and inequitable maternity health systems that have become dangerous and all too often lethal. She is the executive director of her own nonprofit corporation, Common Sense Childbirth Incorporated, which operates a training institute, health clinics, and a birth center in Orlando, Florida, and is also the founder of the National Perinatal Task Force, a grassroots organization whose mission is the elimination of racial disparities in maternal child health in the USA. In July 2020, her school, Common Sense Childbirth of Midwifery, became the first and only privately owned, nationally accredited midwifery school owned by a Black woman in the United States. Jennie is a founder and a proud member of the Council of Midwifery Elders. She serves on the advisory council for the Congressional Black Maternal Health Caucus, is a fellow of the Aspen Institute, and has been recognized as Time Woman of the Year 2020 for her work in promoting perinatal equity. So thank you so much, Jennie, for joining us today. We can't wait to hear your presentation, and I will turn it over to you.
Thank you so much, Anna, and your co-chair and everybody else. My apologies for not being able to get on earlier. I had internet drama on my end, but it was really great to then be able to listen into your conversation. I was in and out a little bit, but I got the gist of it, and wow, what a lot of work was done in this last session in terms of just really calling out what's the problem and coming up with solutions. I entitled my presentation Saving Lives, and it sounds a little bit dramatic maybe, but I've been in the United States since 1989. And I really believe what happened for me was I had to figure out how to practice midwifery the way I had been trained to do midwifery, the way I love doing midwifery inside of a very essentially maternotoxic country. And also recognizing that in the absence of that type of care, women's lives are literally at stake. And as I go through, I hope you'll have some thoughts and some feedback for me. Appreciate your input, because as you're talking about really what is the structural issue, this is what is at the crux of all of the issues that are impacting our families and ourselves as midwives and providers. So the main thing I want to get across here is that we know the problems, like we've already said, that we know the research, there's plenty of it, there's no shortage of it. And when you state it in plain facts, plain language, it kind of overwhelms you. But from the United States perspective, their issue is quite pitiful in that, one, they're the worst, dead last as far as maternal mortality and morbidity in the developed nations. I'm not sure how far back they are with infant mortality, but they're pretty rotten as well. And essentially, the racial disparity is even more stark and more egregious. Twice as many Black babies are being born too soon, too small, too sick to make it. And of course, the women are dying too. 3 to 4 times as many Black women as white are being lost. Native women, we don't even have enough data, but we know they are equally as high in that disparity, 3 to 4 times as many. Latinas do a little bit better, but still not the same. And so we've been talking about maternal mortality now for the last maybe 5, 6, 7 years. We used to only talk about infants. Then we remembered that actually those infants were coming through people. So we should maybe think about that. At this point in time, we're about 2 to 3 women dying daily in the United States, which is in and of itself, compared to other developing nations, not a high number. But we're not a developing nation. That's the problem. There is no excuse. We have more resources than we know what to do with. The other thing, though, that's really important, and I always stress this when I'm talking about it, is that we are not really capturing morbidity. Here's the problem with morbidity. If you're not dead, you're not a statistic, right? Like we can say, yes, categorically, X number of women are dying during the, childbearing period. But 50,000 is what you hear sometimes, 60,000, I hear that. Those figures are around that same number each year, nearly died, near miss events. Well, actually, come on, which, women are really the ones that are vocal about their near-death experience. You're leaving a hospital and you're leaving from the ICU or the CCU, the cardiac care units, the stroke units. You're not talking to anybody, nor is anybody collecting the statistic because you're still alive, you're leaving. Likewise, how many people in the postpartum period or even in the pregnancy get to really talk about their near miss? Who's taking that data and writing it down? The vast majority of postpartum pregnant women are depressed, are overwhelmed, are beyond coping, and suck it up and get on with it, because that's what women do. That's what people do who are marginalized, who are under some type of injustice. You suck it up and you go on. So sometimes I, wonder, could this number be 200,000, 300,000? Is it 500,000 women annually? There's 4 million births in the United States. So come on, 50,000 near miss? No, it's time to tell the truth. That's one of my hashtags. You see here in the picture, this was back in 2010. This is when it sort of started becoming, something to discuss. This is me at the Capitol with the Amnesty International group that raised the alarm about maternal health and particularly about Black women dying in the United States. Amnesty International had to start this conversation. That tells you where things are. So yes, I'm a British trained midwife. I'm very proud of that. Here's me in my little uniform. I trained at Edgware General. I graduated in 1981. I was in the first batch of direct entry midwives that were trained in a hospital in the United Kingdom. And I was a graduate, class of 1. I was the only one who graduated that class. And the second class behind me, you may know Nikki Leap. She was in that class, several other folk. I know Jane Sandel went through Edgware. Like there's a lot of us Edgware alumni, and Edgware really was quite a leading hospital back in the day. I've been in the States since 1989. So let me just double back real quick, because as we've been talking today, as I've been listening to you guys today, we already know this, because when we work from our place of humanity, when we work from that, center that is all of us, our heart, we know that what we want for our family is what we want for everybody, right? Midwifery is a profession, is a calling, is a vocation where we agree that we are centering mama baby. We're centering mama baby family. That's who we are. Midwife is with woman. That's what we do. But when we don't have them centered, then we end up with what we got, what we're talking about, what we're concerned about, what we're trying to do. We see that if the patient isn't centered, everybody's suffering. So it's not just the patient, the mother, baby, the family, the community. It's us as providers. We're miserable. We're all of us feeling the moral injury and the pain and the pressure and the frustration, the helplessness around the suffering and the concerns that we have for maternity care wherever we are in the world. The systems and the structural ways that we have set up to provide these care systems are harming everybody. Because you know that you wouldn't want your family member, your sister, your mother, your mother-in-law to be in a system that is broken if you didn't have to. We know the level of care and quality that we're looking for every person, every time. That's the work we do at Common Sense, because what we realized was that was sorely missing. So here in Orlando, I've been here since 1989. I started doing home birth because I couldn't get a job at the hospital because I'm not a nurse. I'm not a registered nurse. I also had to kind of find my way because I was not let into the system as a midwife, and particularly as a Black midwife, which is also relevant in terms of how the United States operates and how many systems, when it comes to the fact that racism, classism, power, etc., play into midwifery. So I started doing home birth. I then moved on to doing birth center birth. And setting up a birth center in the United States is a whole thing in and of itself, and an entire another talk. But what I do want to mention about this is, if you want to compare it to the midwifery units that you guys are talking about, that's what a birth center is. In the US, it's basically a freestanding, independent clinical space where births can happen in the community. And it's typically midwives who own and run those birth centers, although some physicians own and run birth centers, some nurses own and run birth centers. So state by state, different rules and laws. Some states, you know, they do not support, others, they are all about it. And it's always done from an entrepreneurial perspective. They don't belong to the health system. They're not incorporated into the health system. It's fringe. It's like being an independent, you know, entrepreneur, basically. So here in this picture, I'm using this picture to sort of share what it's like for me as a birth center owner and operator when I have a birth center client that needs hospital support, needs a transfer into hospital to complete the birth. So you can see here, I'm here, the mother has been admitted. She was in second stage at the birth center, pushed for about 2 hours, no progress, no descent. She was getting tired, and I'm not playing around. If I'm in a birth center environment, especially in the United States, there is no backup. There's no flying squad. No one's coming out to help me. If anything, I now have to begin this big process where I hope and pray that we are received well, that we are acknowledged, that the mother is treated, you know, with respect and dignity, and that we can make the transfer without anybody falling out. And of course, you know, half of the problem is, of course, money. Who owns this patient once she comes into the hospital? She's not mine anymore. Not only do I have no power in terms of her management care or orders or any of the, you know, next plans, but I also can't bill for this care because I am not privileged to have access to that any longer. So here she is. She's been accepted into the care. The nurse is smiling. Everybody's doing well. Mother's got a little oxygen on to help her. They just put the monitor straps on to start listening to baby. And we're getting ready to figure out what to do with this mom who's essentially having a, you know, a delay in second stage. The doctor comes in, and the doctor happened to be white. I mention that because you'll see along the way where these things do make a difference. This woman and her partner are white. The doctor came in, very sweet, very willing. Hey, Jennie, good to see you. Thank you for bringing her in. Yeah, let's see what's going on. Examined the mother and said, you know what, your pelvis is adequate. Let's see what's going to happen here. Let's try a little bit more pushing. Let's get you comfortable and see what happens. Sure enough, she delivered the baby. The baby was born. The doctor assisted. Everybody was happy. Underneath of that towel, you can't tell, but there's a big old 10-pound baby. She had a big old fat baby. She'd had 3 other birth center births with me. All of them were like 7, 8 pounds. And for some reason, she made a big old heffalump baby this time around. But nonetheless, she got the vaginal birth. And you see again, look at that face. That face just tells it all. She's relieved, she's happy, she's joyous, she's safe. The nurse is happy. I'm still thrilled because nobody tossed me out of the door and said, you can't stay with her. Dad's happy, triumph, we're good. And that's, the, you know, sometimes a typical transfer for my cases into the hospital. I've done a lot of work over the years to create collaborative arrangements, collaborative agreements with these people. So we win. Birth center standing alongside of a hospital, although not part of the hospital system, not integrated into the hospital system, and certainly, depending on which way the wind is blowing, not even accepted sometimes as part of a bona fide way to take care of women. So I came up with this term, maternotoxic, because in the opposite of that, in the opposite of the collaborative, willing, you know, transfer of care and the cooperation, what happens is what I call maternotoxicity. In other words, it is not an environment that is safe for this mother. The impact on the mother could be really harmful to her, her baby, or even, you know, her family. So there's no safety for that mother or that person inside of a maternotoxic zone. Well, you would then think, oh, those maternotoxic zones must be outside of the institutions, because clearly a hospital is a safe place. That's what it's for. So people often ask me, well, Jenny, what do you really mean by maternotoxic? So here's another way. Go back to what I said earlier about if it's yourself or your family. If it was you and you wouldn't want to be in her shoes, you wouldn't want to change places with her at all, you wouldn't want to be in her situation, then it's likely to be a maternotoxic situation. She's compromised. So of course, people, especially in the United States, love to jump up with, oh, you mean those neighborhoods, those rotten areas where these women are living in, you know, violence and stress and poverty. Of course, they're maternotoxic. No wonder no one can thrive in those kinds of neighborhoods. The social determinants of health, that's to blame for these outcomes. That's the reason why these numbers are so high. These people are poor, they don't eat right, they don't behave, they don't get good care. Okay, all right, that's definitely part of it. Those are maternotoxic zones. There's no argument for me on that. But let's talk a little bit about what I call pop-up toxicity, because this is the kind of toxicity that finds you, whether you're looking for it or not, no matter where you are. So in this series of pictures here, you can see this young lady on the left in this picture. She literally, like seconds ago, delivered the baby. She's in an ambulance. The reason she's in an ambulance is because she came to one of my clinics. I have clinics where I don't provide delivery services. I do outpatient care, antenatal care, and postpartum care, and some women's health. We do that on purpose because the majority of American women want to have a baby in the hospital. They don't want a natural birth in the community with a midwife. They don't even think that that's a normal thing to do. It's only those few folk who have learned and understood and have some power and agency who choose natural birth in the community. Everybody else wants a hospital birth. My work in terms of reaching people who are not getting good outcomes and are at risk for poor outcomes has been to say, well, let's create clinic settings where at least you can get midwifery care during the clinical outpatient phase and still have your hospital birth. So this young lady came to clinic as usual, 38 weeks in her pregnancy, coming for a regular appointment. While she was waiting, she was pulling all these faces and getting all uncomfortable. By the time I got her onto the exam table, checked her, she was 8 centimeters. So of course we're like, oops, here we go, baby's coming. So we called the ambulance because she was planning a hospital birth. We are not trying to change her mind from the birth that she wanted. And we were therefore not going to force her to stay in the birth center and have the baby, but rather try to get her to her hospital as planned. So I jumped in the ambulance with her because I was worried she was going to deliver. And yep, sure enough, we went round the corner on 2 wheels and the baby, here's the baby. But look at the baby. I've got the baby skin to skin with mama. You see the baby's pink, the baby's crying, the baby's fine. Mom looks completely blindsided. She barely knows what happened. You know, 1 minute she's in the clinic minding her business, next minute she's a mother. This was her second baby. So that was another reason why it went so fast and smooth. Anyway, we get to the hospital, and in the second picture here, you see her here, she's resting in the triage at the emergency unit of the maternity hospital. It's a maternity hospital, specializing in mothers and babies. So the emergency unit is not like a casualty department where you've got broken legs and heart attacks as well. This is only mothers and babies. So we go into the triage department. Again, please look at the baby. Baby's pink, baby's rooting, baby's settling, and mom's coming around as well. You see how she's coming to being much more engaged again and realizing what happened. Here's the problem that I want to outline, and I want to make sure you get what I'm saying as far as why the maternotoxicity showed up around this mother. First drama was, oh my God, the baby's born in the ambulance. Like, so what? But that was a big thing. Why? Because now we go back to capitalism, we go back to structural and institutional ways of being. The doctors, because in America, the doctors deliver babies, and the midwives, if there are any, are relegated to, you know, you just do these few people, everybody else is far too out of risk for you. So OB doctors, fully trained obstetricians, are running around like chickens with the head cut off, because now the argument is who's going to deliver the placenta? I haven't cut the cord. I haven't even clamped the cord. The placenta's still in the mother. And the big panic in the triage department is, who's going to deliver this placenta? Because whoever delivers the placenta gets to do the billing. Okay, follow me now. It's about money. It's about power. It's about structural, deep historical ways of being. Well, the other thing that goes along with money is insurance. And low-income people have a certain type of Medicaid insurance, which is a government insurance, which means you don't get much money for any of the things you do, that if she had regular insurance, you'd get a whole slew of money. And so this is where some of the disparities also show up. The physicians, the hospitals, everybody knows the difference between someone who has Medicaid and someone who has regular insurance. So the argument was no one was going to own up to taking on delivering this placenta because they wanted to figure out who should be taking on this responsibility for the financial. They went round in their circles. Anyway, long story short, the placenta was delivered and mother was treated with, okay, well, you can go upstairs now, everything is finished. They took her upstairs to the labor and delivery. I did not go with her because as far as I was concerned, everything was finished. Baby is out, baby's happy, baby's doing well. Placenta is out, mother's not bleeding, there's no problem, morbidity. I'm not concerned about her health or well-being. I went back to my clinic. Here's where I made my mistake. Unlike with the first patient I showed you where I stayed right through to the very end, this wasn't the end. You thought it was the end because the placenta's delivered, mother and baby are fine. That wasn't the end. When they got to the labor and delivery floor, the nurse rested the baby off of the mother's chest and said, this child needs a bottle because it was born in the ambulance. She put the bottle in the baby's mouth, even though the mother said, I want to breastfeed. Even though the mother had successfully breastfed her first baby, even though the mother was fine and so was the baby and they were enjoying that golden hour and the skin to skin care had been continual up until that point. But that nurse decided that that baby should be fed right there and then, just assuming that that baby would have had a low blood sugar, that this mother wasn't nourished. I don't know what she was assuming, but that mother and baby never established the breastfeeding relationship. Maternal toxicity. She was in a hospital surrounded by craziness, interfering with her ability to finish out this perfect physiological birth that she had just done. Inadvertently, but certainly it was a physiological birth. The second half of that was completely destroyed. She was not able to ever establish breastfeeding. Look at this child. I mean, it was practically on the nipple all by itself. So we know, and we've got plenty of details from our, colleagues in Canada. Dr. Saraswati Vidam and her team have done extensive work, and now we have quantified even the mistreatment, the experience of mistreatment during pregnancy and birth. People of color experience more mistreatment in birth in the United States. Just the things that you hear about where we would automatically assume, oh, only in developing nations, under-resourced nations, surely not in America. Yeah, in America. Top 4 types of mistreatment, privacy, threatening to withhold treatment. What she experienced was a version of mistreatment. Her child was forcibly fed a bottle for no valid reason whatsoever. This is the level when maternal toxicity shows up and permeates without us recognizing what it actually is. So you could talk about the Serena Williams story where Serena was ignored to the point of she nearly died. If she hadn't been able to keep standing at that door and telling the nurse, I need help, she would not be here now. Her child would have been left without a mother simply because Serena, with all her money, her celebrity, her power, was in a maternal toxic zone. So again, we have enough evidence. We have to ask ourselves, what is it that has us continually condone and agree that this kind of behavior is acceptable? The structural way that we do business, because it is business, in maternity units, in institutions, in clinics, and even in private practice, is what is killing mothers, babies, and destroying families and communities. Again, maternal toxic zones can be lethal then. They lead to the increase in morbidity and mortality, widening racial disparities and outcomes. But the impact on the providers is also equally devastating due to the vicarious trauma, the moral injury, sense of helplessness, and overall lack of power. I stress it because I need us to understand, as we start looking at solutions, we have to also remember to take care of ourselves as we find those solutions. It is of no value to then create great interventions that will destroy us as providers along the way, any more than it is to focus on, let's continue to ignore the structural situations that we have and pretend that we are going to create some solutions inside of those. No, the two things don't go together. Okay, we do know that quickest access for the mother baby is respectful maternity care. There's no arguing, and that is a safety factor. So the fundamental premise of the work I do, I call my program the JJ Way, but basically every woman wants a healthy baby. Every woman deserves it, deserves one. And also it's time to stop blaming women, because that's where we go wrong. We want to actually turn it around and take the onus off of the patient, the mother, baby, the person, and turn it right back where it belongs. Our work is in looking at these systems and understanding them. This is why I'm so thrilled that I was able to be a participant today as you guys are going through these thoughts and processes and conversations. This is how it has to be. We are the ones that have to make these changes, because what we're doing is we're doing trauma-informed care for our clients, our families, but we also need to do it for ourselves. Okay, we must have the same access, the same connections, the same knowledge, and the same empowerment that we are fighting for these families. So we work at our work from two angles. One, for the mother baby, for the family, for the community. We want them to have access to quality and safety. We want them to be connected, to feel that they can trust because they're having respectful care, they're maintained. We want to share our knowledge, but we also want to hear what they have to share about their own knowledge about themselves and their needs and their autonomy. And therefore they will be able to be empowered. And with the staff, the same way. We've been able to find out how can our staff get their best work done and feel safe and feel acknowledged and to feel like they have a part in the solution. That key, the access to that changes how we have enough energy and verve to keep going. We feel more of a team, we feel more connected, and we therefore can learn and share new learnings, best practices, and then we in turn become empowered to change this broken system. So I'm not going to stay too long on these slides. You all know about these, the safe motherhood, all of this. Safety is that word, safer system. How do we get to a safer system? Is it possible that we could create a culture, an environment inside of the systems that exist that support all pregnant people, that could make the difference between health, gestational age, birth weight, and breastfeeding rates in women who are at risk for poor outcomes in the USA? We asked that question and we think we found the answer. And one of the simplest things that we did, the immediate interventions we did, was let's listen. Listen, just do that in and of itself. That doesn't cost money. You don't need any special training. You just need to be in your humanity. Just listen. And in listening, you can learn so much about what will work for both mother, baby, and provider. No one listened to that mama when I transferred her into the hospital. They were only interested in worrying about what they needed to do for themselves, their unit, floor, their protocols. Everybody was in high alert because they felt threatened that with this woman not having been under their control from the beginning, they would be in some type of jeopardy. That's where listening comes in. Listening counters that immediately. So we do our listening in what we call perinatal safe spots. And they created lots of areas where people can come and get information, understanding that we will help guide them and navigate through systems, because after they share what they're looking for, we can help hook them up with what the easiest way to get that. The access, connections, knowledge, and empowerment is an ongoing part of the clinical protocol, which is really interesting because at the end of the day, we're not doing any fancy midwifery, but we're adding these wraparound components to the midwifery. And I'm also using community health workers and doulas and childbirth educators and lactation educators as midwife extenders, if you will, people who are also doing the midwifery model of care, but they are actually paying attention to what the client wants. So we can create the patient-centered, client-centered care using the midwifery model of care with people who aren't midwives. A lot of the work I had to do when I got to the States was to let go of trying to be the one, trying to be in the middle, doing the midwife-centric care. I love doing midwife-centric care. I'm such an egomaniac. I'm all about, let me be the one, let me be at the perineum, let me do my fancy maneuvers. Aren't I awesome? But when it came down to it, in order to scale and to reach as many people as we could, especially working in the community space in the United States, we realized, nope, we can't do it that way because there aren't enough midwives. I can't train fast enough. We can't be sustained even if we get out there. We cannot keep practices up and running because we're working outside of the system. So we now have developed the perinatal safe spots. The perinatal task force is the organization that houses perinatal health workers, whether they are midwives, doulas, childbirth educators, lactation, whatever, that are on the ground in maternotoxic areas, trying to mitigate that maternotoxicity by offering access to their information, their support, their encouragement, their health navigation skills, the collaborative care, making a way where the clients on their own can't make a way. They aren't going to ever be able to break the system down and figure it out. We're using a model which we believe is what the grand midwives, so-called granny midwives, used all those decades ago. We found a way where there was no way to provide maternity care for community to community, especially in the southern United States. When Black midwives were enslaved, we found a way to make a way. Black midwives delivered America. African midwives are the ones who kept the commodity of human beings alive and created wealth for the United States. Indigenous midwives continue to deliver their communities because we know that midwifery works. Midwifery that has been enveloped into structural and historical harmful systems cannot work. And midwives can't thrive inside of those systems either unless we create ways that benefit both us and the clients that we care about. So here's some of the outcomes that we got while we started doing this work in terms of providing wraparound support without delivering in the outpatient clinics, I call them easy access clinics, and the perinatal safe spots. We've been doing this a long time. I've been gathering stats for as long as I could gather stats. Doesn't make a difference. No one's moved. No one's rushing to say, well, let's just do what Jennie does. No, I'm not that unrealistic that I'm expecting this immediate embracing of let's have poor and low income and marginalized folk do better. That's not what's going on in America. But look what happened when we did implement our model. This was the first study we did in 2006, 2007. 100 women were enrolled prospectively. These are women who were in the easy access clinic. They weren't choosing natural birth. They were going to the hospital. Black women at that time were at 20% prematurity rate, 1 in 5. For what reason? Oh, because you're Black in America? That's the reason why your cervix can't hold? The white women had an under 5% rate compared to the 13, but the Latinas also, they didn't have any premature baby during our study. Same with low birth weight. We did that by applying midwifery model care in the outpatient, prenatal and postpartum care. It wasn't even about the birth. It wasn't about the delivery. So we eliminated that disparity in 2007. 95% of the babies in the study weighed an average of 7.5 pounds. 95% of the women delivered at 39 weeks. Every time we do a study, we get the same outcomes. This is the 2014 study where we did matched pairs to see what would it be like if the same type of demographic, the same zip codes, the same maternotoxic area, and the patient had also received prenatal care. Let's compare people who had prenatal care at another clinic compared to having prenatal care at our midwifery-led easy access clinic. Let's see what happens if you provide access and connections, knowledge and empowerment, the 4 main cornerstones of this work. Guess what happened? We came out statistically significant again for longer gestational periods, lower preterm birth rates for the women of color. 2017, we did another study. This one, we had 256 women in this study, prospectively enrolled. Again, we beat the preterm rates for the lower than the state and the country for Black women, 8.6% that year. This is something that, it's hard to believe it could be true because we weren't doing anything special or spectacular, and we certainly weren't doing anything expensive. We weren't giving them shots to make sure that they didn't go into preterm labor, or we weren't, putting them on bed rest or putting cerclage, Shirodka sutures in their cervix. They just went to term. So again, is it the environment? What is it that had that happen? We just came up with these common sense solutions, and it seemed to be very effective. So again, community-based, community-owned, community-led. Our providers match the people that we're serving. We have a Spanish language clinic. We used to have a Portuguese language clinic for the Portuguese speakers. We have Black and Latina staff. We have white staff. We have a cross section, and we are trying to stay culturally congruent to keep the safety that we know is necessary for the care. And in all maternal toxic zones and situations, our approach is protective. We work as a team. We keep our eye on the quality and the safety, the physical, mental, emotional, and even the financial support, because so many people can't afford the services. So many people haven't got the right insurance. We don't turn anyone away. But I also did my work in terms of getting to connect with the hospitals and other providers, making sure that we could all get along, making sure that no one was getting all out of sorts or feeling that I was being antagonistic, having them understand what we're doing is the same thing. We're trying to get to the same outcomes. So what do we need? We need support for the safety and quality in maternity care for everyone. We need appropriate level providers. Come to find out, anybody can do midwifery model of care. You don't have to be a midwife. Once we got over that, it was like, wow, all these willing folk who are willing to provide care where they center mother baby, that's it. That's it. Access to any site, whether they want a home birth, a clinic experience, a birth center experience, or a hospital birth, that's their choice. So the stakeholders need to look at this from another angle, because once they have access to understanding these inbuilt historical and structural harms, this disconnected and broken and unwieldy medical system, they will be willing, I'm sure, to help us all move towards centering mother-baby family again, right? The providers also need to understand that we need the cultural humility support. We need to dig in and understand how can we better ourselves as providers to be congruent with the people who come to us for help and care. And of course, I've got a school. I'm all about, let's get these women educated, people educated. Let's get the scholarships, the loans, etc. This is what you get when you do my model. This is one of our postpartum groups. These mothers are all breastfeeding. These babies are all chunky. All the thighs have rolls. I mean, it's not that complicated. What are we doing that's different or special or expensive? Nothing. We're opening a space. We're providing access, we're providing support, we're listening, and everybody takes it from there. So we're doing midwifery from a public health perspective, maybe, but we feel like the onus is on us if we are going to stop reporting on these horrendous statistics in and out. We have evidence-based outrage. We are sick and tired of this evidence. We don't need any more. We want to look at it from a perspective of, we need a different change, we need a different outcome. There is no more time to waste. We have no excuse. We looked at these, listening to the mothers, the Giving Voice to Mothers study. We just put something out a couple of weeks ago, and the study is now, the report is out there. Go to the Birthplace Lab website that's got amazing resources on there and really spells out what the mothers have said. And no one's surprised what they said, because we all know. And if we didn't ask them and we didn't hear their voices, we would still know. This is where we take the responsibility of fixing this. So, and again, it's time to stop blaming them. No, they're not too fat or too stupid or too ugly. They didn't leave the ICU or the cardiac care unit after having a baby because they just chose to be wanton and irresponsible. We have to stop with that kind of approach. So I would love to take questions. I would really appreciate hearing from you guys. What do you think about what I'm sharing, and how do you see that it can be incorporated either individually or even, again, structurally? Can you recognize maternal toxicity when it shows up, and how are you empowered to do anything about it if you are? So I'd happily take questions if you've got time. Yeah, we've got a few minutes.
Yeah. So thank you so much, Jennie. What a fantastic talk. As you said, we're opening up the floor for questions. We've got about 10 minutes
Okay.
for questions. And if you have time, or if you'd like to stick around, Jenny, the next from 8 o'clock British summertime will have in half an hour to kind of bring in all of the discussions from today, if you want to stick around and join in on finding these solutions, because you seem to be really spearheading some of the solutions. So opening up the floor, people just want to either raise your hand, jump in the chat, or yeah, opening up the floor now.
Go
Okay,
ahead.
Claire, I think you've raised your hand.
Hi, thank you. Thank you very much, Jenny. I was very excited to meet you. You're a bit of a little celebrity in a little local group that I manage here in Germany. We're celebrating you. And many of the women actually here that have been here today. I love reading so much of the output from so many of you. What I loved just at the end, there was a photograph of all your amazing birthing women who are standing around with their big chunky babies and their gorgeous thighs. And I wonder, you didn't say it explicitly, but it's something that we were talking before about our ideal birthing systems. And I think one of the great things that I would love to see in my community is to have group like prenatals, or there's only so many times that a lot of busy women in this community will have time to go in to see their care providers, and if they're at the same time with their peers doing something that's important, then that peer-to-peer interaction seems to make good ideas burn like wildfire amongst them. And I absolutely love it. I think maybe if that's something that is a part of your practice, I'd love to hear it.
I love the centering, they call it centering pregnancy here, group prenatal care concept. I think, to get more of that, we as midwives, as providers, hopefully, people with some power inside of the organizations that we work within could actually make it easier for them to get that done. So one of the pictures I showed was where one of the doulas was talking to the waiting rooms couple. We wait our waiting room in a circle, because when the mothers are waiting on the appointments, they might as well use that time to be in group. And so the circular chairs, so everybody's facing each other, everybody gets to connect with each other, but also I always staff the waiting room. The waiting room is not just the waiting room. So instantly everybody's in group prenatal care, they just don't know it. I don't claim it, I don't run it that way, I don't have it, but it's part of our model. You're in the waiting room. So like the young lady that was in labor, 8 centimeters, waiting to be examined, they came to me, somebody already come and told on her. She got a look on her, Jenny, something going on. You better ask her when she comes in what's wrong with her, right? Because they couldn't get it out of her in the waiting room. But this is like the gossip session. Like someone comes running down the hall, Jenny, she's looking, like what's up, right? Like they take care of each other because we begin to create community. Now, here's the most important part, Claire. It's great for exchange of information and support and connection, but what it does physiologically is what blows my mind. How is it that cervix locks tight? If you can match pairs in the same demographic, same situation, same level of socioeconomic status, blah, 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 race and everything, and you still can make a difference by putting somebody in a group waiting room, how are we not then embracing these easier, readily accessible things to all of us? This is where I'm saying, look inside of what you're already doing and see where you can already just get in action. All these meetings and hand wringing and crying about budgets and all that, it's got nothing to do with what we can do right now, right? Because if we let the families lead, they will tell us exactly what they want. They want community. They want support. We have to figure out how to extend ourselves before we kill ourselves in the process. We midwives are dying. We are stressing out. We are burning out. We're leaving the profession. We have to get over that. What is the point of that? I mean, I know you guys are doing continuity of care in England. It's a new thing. Okay, great. Except for how are you going to survive that? Just asking. Like, what is that? You're going to destroy your families and yourselves, your lives, your career to do continuity of care in a system that's still broken? I'm just saying, I mean, I'm not trying to be controversial, but we know that the piece of work that we do with continuity of carer is the same piece of work that your neighbor could do. Your co-patient could do, your doula could, there's other folk who can do all the loving and holding and listening and all of that. We could get over ourselves. We really could. We could empower other people and other structures so that we can replace the broken structure. I'm an old community midwife. I worked the district when I was in England and I loved it. But I used to have a caseload of 25 and 30 patients a day back in those days. Ridiculous. No wonder it didn't last. So group is a great way to get the best bang for your buck, given the circumstances we're in, the constraints that we have. The toxicity is moved out when the group shows up. Because it's group, the group is not about us. We're not in the middle of the group. And that's the key. That's the access point to that, change. Thank you for that question.
Thank you. I think we had Lucia had her hand up as well. Did you have a question, Lucia?
Oh, wow. No, I'm just, every time I hear Jennie, I'm like, oh, and it's so, I keep reflecting backwards and forwards in terms of what is not working in the UK and some of the solutions and the anger, because the solution is there and we know what works. And yet, all this rhetoric of implementing continuity of care, but is all really like cosmetic, is not real change.
Yes.
Oh, sorry, I'm mad.
I just think though, we have to be open to helping ourselves and taking care of ourselves while we do this work, right? I mean, and even just like you mentioned, it's work for Valentina to have to speak out, in another language to participate and share her thoughts and ideas, and also feel some healing and some, relationship about someone understands and hears her and knows what she's dealing with. This is the work now. Let's rebirth midwifery because we lost our midwifery along the way. And yes, it makes you very upset, very frustrated, very angry. But we also have power if we wrest that power back in a purposeful way to not keep going in circles, right? And to recognize how we can support ourselves and each other if we can come to agreement on what we're trying to do now, right? We cannot break down a system. I thought when I first got to the States for the first 10 years, I was like, let me just burn this thing down. What a stinking mess, right? We have a dilemma in America. Obstetricians take care of all pregnant people. That's the biggest cause for this problem in the first place. That system isn't going to change because it's about money and power. Even if we get the midwife workforce built back up, we can't take back that power. It's too much money. So we go to the community, which is where we've always, as midwives, gone, which we've always been able to sustain. Community work has been the main staple of midwifery worldwide and always will be. So how do we marry and mesh these ways of being safely for ourselves as midwife providers, at the same time helping the families that are looking to us to help them to get where they need to go? That's my reality. I think that we're finding our way slowly and surely, but these kinds of conferences, these kinds of discussions are key. They said to Lucia, thank you for doing the work you're doing. It's about saving lives, not just mother baby, but our own lives. We midwives, we can continue a legacy of, at this point, disrespect and, harm, or we can break it now and get moving on reestablishing our profession, our vocation, our heart, our lives, the way we've done historically. If midwives could manage through slavery, then what's wrong with us? Come on. Think about the power of the African and enslaved midwives who delivered every single person on every single plantation and every single village and hamlet and town. You have your hand up, sorry, Anna, I do go on.
Oh no, I'm just like, you are, I don't know, preaching the gospel of midwifery right now. I'm loving it. And so I really think this just flows nicely into our discussion that we were going to have at this time. So please stick around, Lucia, Cassandra, Donna, if you're in the room, you know, please open up your mics. And if I may take advantage as hosting, just to start off the first question with Jennie, I loved the way that you conceptualized maternal toxic environments and pop-up maternal toxic environments. And I was just wondering if you could elaborate, particularly on the pop-up environment. And is, you know, I'm just thinking, like, as a Black woman, do these environments just, how do they pop up? How do they present? Is it because I'm in these spaces? What makes these environments pop up? Because in the static community, I can see it, but the pop-up is what I'm particularly interested in.
Well, you know, this is why I'm trying to find names, just ways of renaming things so that we can then rethink things. If you consider that we're talking about safety, then the answer would simply be yes, well, she needs to be in the hospital because it's safest. That's why the worldwide effort to move people from community birth into institutional birth is supposed to be about safety, right? That's why we deploy all these teams out into, you know, remote areas to take those traditional midwives and get them straightened up real quick so that it can be about safety, right? So at the end of the day, the safety we already assume is in places where we wouldn't ever imagine maternal toxicity to be. So the popping up inside of the safety is, the best illustration is Serena. Serena really helped encapsulate for all of us. What does that mean? Well, it means that you can be Serena Williams and still almost die having a baby in the United States. That pop-up showed up. Now you can imagine, let's just pretend we're on the floor, we're on the ward, and we are the nurses, the midwives, the teams that are taking care of all these other women, including Serena. There's no way that nobody knew that, oh, Serena Williams is in room 3, right? Who would not know if you were working on that floor, right? So it wasn't that toxicity was across the entire ward, but it happened to be around room 3. Why? Because Serena was in it. And pop-up shows up in relation to who the person is being othered. In her case, she's a Black woman. It doesn't matter that she's a superstar, millionaire, brilliant athlete. She's still a Black woman. In America, that trumps everything. And the response that that whole team of nurses and doctors had to her being a Black woman was she wasn't listened to. She was dismissed, ignored. Her pop-up showed up around her room, or even the hallway when she was in it, or, you know, even the OR. She went down to the OR. No matter how hard you control for your behaviors and your implicit biases, prejudice, or whatever, she's still a Black body on the operating table. Okay, how that plays out, for example, I've had more than enough clients, I can't even count them, I don't want to, who during their C-section, telling the anesthesiologist, I can feel the pain, and being told, oh no, you can't. Never had a white woman yet to this day in 40 years of practice who was told, no, you can't feel the pain. She's a Black body inside of the pop-up toxicity that is the systemic and historical and structural harms that we've been built into the system. Now, we can go into sexism, why not? We might as well. Whether there's a male or a female provider, if they're working under a patriarchal system that says this is how we behave and it's condoned, that's how they behave and it's condoned. Now the toxicity popped up again, right? So it's about power, and toxicity will pop up with the least, where there's less power, more toxicity. They go together. Okay, so it's really not just about, well, I'm a prejudiced racist person and I'm bad. No, I'm in the side of a prejudiced racist institution and I'm going to comply because I want to keep my job, or I'm scared to say something, or I don't care. Doesn't matter, because all of it's condoned. All of it. Do you think the nurse that wouldn't talk to Serena, wouldn't call the doctor, got fired? No. So it's that insidious, but it needs to be named. Then we can address it. We can even control for it, because we can share with people, think a minute, does that baby really need a bottle, or are you just reacting to what you think is going to happen here? You haven't even taken the flipping blood sugar to know if the child needs any sustenance or not, and why not just stick it on the nipple then? You know, like that's the level and the insidiousness of it, and how it sneaks past all of us, right? And it's not about the individual. That's the reason why you have to stress it's a structural issue.
Amazing. Are there any other questions? I know earlier we were talking about how we reimagine systems. How do we reimagine midwifery-led care? I love what you mentioned, Jenny, about midwifery being almost a philosophy, midwifery being a spirit that can be extended to anyone. And I love how you mentioned that we need to take care of ourselves. I'm not a midwife, but just people in this work taking care of ourselves.
That's why I use perinatal a lot more than I use midwifery these days. You know, a lot of times I'll be sharing what I do and why I do, and I don't even talk about midwifery because it's about perinatal. I have such amazing teams. My best supporters are the people with lived experience, the people that have been through what these women are dealing with, what their families are dealing with, the people that have been on that stupid government Medicaid insurance that no one wants to take. That the minute they see that, they'll put a note on the door in the labor and delivery, what insurance you have. Why would that be relevant? Right? These are the structural things. So when people are looking at who can do midwifery-like care, anybody who has a heart, anybody who has an interest in supporting in a genuine way, anybody who understands the white ribbon, you know, respectful care, World Health, all of those things that we make, and look, all the infographics and all the lovely materials, anybody who believes in any of that can practice midwifery model care, because it's centering that mother, baby, that person, and recognizing that there isn't anything here that will bring toxicity to your situation and your environment. Nothing will make it worse. That's midwifery care as far as I'm concerned. Do no harm. Be with woman, be with person, be with them that need you because they asked for that help. So imagine, to transform a large system that's broken, you can't really do that and be fighting against the man all day long and expect to survive that. Right? So therefore, we have to agree that as a profession, we work with each other, for each other, on behalf of each other, to take on the structural. It can't be, let's come up with a little one thing and let's go running and let's make it the answer. Because what are you going to do with those who will not sacrifice their family to do continuity of care? What are you going to do now? I burnt my family out with my shenanigans trying to save the world, right? I regret that. I had one child, I messed that up big time. You can't do it over. Either we're for family or we're not. Like, which is it? Right? These are the areas where we can say, well, hang on, we want to recreate structures around sense and safety for everybody.
Thank you so much, Jenny. I want to bring in Lucia and Cassandra, if you're in the room, and ask, with your work around birth centers in the UK and midwifery units in the UK, how do we incorporate lived experience in the design, and how do we incorporate lived experience in the model of care? Is it something that we should be thinking about? How has it come up in your work?
So if I think about, everything it was said in our workshop, and also integrating with what Jenny has mentioned, and also incidentally, I was here today at home with Becky Reed from the Albany practice, and we had a lovely coffee and a chat, and saying that wherever we go, whatever we do, we always talk about the Albany practice. And in our little experience of the golden age of the Bark and Timber Center, if I talk to people who worked in models that functioned well, and at that time was the best time of our professional life, but also a type of work that was sustainable, gave us joy, and created with sense of community and social capital and creation of health. And very often the pillars, if you see what worked, was very often the same. So being, a team, we shared a philosophy, this spirit of mutual support, and when it's very busy, you feel like you're going to help a friend. You're not feeling like, oh, what the hell is going on here? And that sense of ownership and that curiosity of learning from each other. And, what I heard from Jenny, it really resonates, and what I heard from Becky resonates. And so, again, not only we know in theory, in terms of research, what works, but we have enough examples of how this can work in practice. So really, when Jenny, you were talking, I was thinking, but I know this is my mistake, and I need to really think harder. Oh, well, in the US, you got this broken system, so of course you need to work outside the system. But how do you do this in the UK, where there is virtually no private practice within maternity care? Because in Italy, again, it was clear for me when I was in Italy as a midwife, I had to work outside the system. I had no other choice, but then I was isolated. So really my question now is, okay, how we know what works, we know how it works in practice. How do we make this possible, for example, in the UK within the NHS? And that for me is the challenge that I'm taking home from here, and we'll keep banging our heads. But thank you so much, Jenny, because probably from other conversations, I'm now feeling, after we've implemented the Global Maternal Health Masters, it's been a year of non-stop. And I really feel like, okay, I really need to stop now and do a bit of self-care. So I am going to follow your advice and disconnect for a month this summer and recharge, because yes, I think the taking care of yourself aspect, very often we forget about it. So thank you so much for that.
Oh, thank you as well, because we never really, I think when I was in the UK many decades ago, we had a little bit more maybe latitude to work together, the midwifery teams, the community teams, the district teams. We also had the GPs in the mix back in the day. I don't know if any of you are old enough to know about, the GP unit. That was before it was the midwifery unit or the standalone unit, or, stand alongside and all that. The GP unit or the domino system, I'm ancient, right? So I'm just going to tell on myself. But the domino system was, you would have an early discharge. You come in and you go home within 6 hours from the hospital, right? So there were all these different ways that we were already trying to manage a large caseload, like I say, but also keep ourselves well taken care of. What we did, I believe, when we moved midwifery into the university model, is we created another version of midwifery, which was like, you're an independent soul with your independent degree, and you're coming in and yeah, you'll do somewhat level of teamwork, but not really, right? We didn't have the same when we were hospital-based and community-based. Our teams were like solid and organically grown. And we worked in a different sense of community, right? I don't think we were scared. We didn't have, what I believe is now in the mix for midwives in the UK, at least, is, the fear of the heavy weight of, responsibility on your own. Like you're out there hanging out to dry. Like those are things that weren't there back then. I wonder if there's a way to make the movement back towards how do midwife individual providers connect So the same thing I have for the families: access, connections, knowledge, empowerment. The access to being able to be with each other in a way that is for your own support, and that only, for your own ability to redefine who and how you are and how you're moving through this new system, so that when you are together and the connections get strong, the trust comes back, right? Where there's trust, there's power, right? But we don't have that trust. We're nervous. Everybody's scared. Everybody's wringing hands, pointing fingers, overworking, burning folk out. And then we wonder. So I think the work could be in terms of regelling as a community of midwives. Those granny midwives in the back of the hills trying to service one village by themselves, they made it work because they didn't just depend on, I am the lone wolf. The neighbors, the fathers who had to go and pick up the midwife and drive her up the mountain. All of the team effort that was midwifery was a community-wide effort of understanding. And we midwives, I think, have to start back by modeling our own community again, and then engaging the other greater communities to understand this, including the systems. Think about the numbers of midwives that there are, and yet how powerless you guys are in terms of changing any of these systems.
Wow.
Sandra's hand, it's been up for a while.
That's
Sorry.
it.
Anna, Cassandra, sorry, can I answer to Jenny briefly on the university thing? And that, do you mind? Quickly?
Yes. Yes.
Yeah.
And
So very interesting point. I see in a different way, because at the same time, so I think we need to look at what happened historically. Not only there has been the, creation of universities and the move of the training into universities, but also there has been the centralization of maternity services, the closure of small obstetric units.
Yes.
My husband is an obstetrician, and he always tells me when he trained, they were working, these tiny little hospitals were amazing. They were having parties, going out together, the whole team. And it was this sense of trust and relationship.
Yes.
And there wasn't that barrier between midwives, obstetricians, cleaner, support, help, so he really, he started hating obstetrics when he was sending these mega units. And I arrived in England at that time, so I've never experienced these small units, but I have seen it in Italy. So I think, it's not necessarily the university which has created the issue. The academic knowledge, I think for us as midwives is so important. I was trained in Italy where midwives were not really academically trained that much. And that hierarchy with the doctors was terrible. So I see the academic training as an advantage, but that cannot be the substitution of the relationship and trust. And so it's not necessarily, the aspect. And sorry, Cassandra, I know I jumped in front of you. Apologies.
No, it's absolutely fine. I was just going to sort of respond to what Anna had been talking about earlier about lived experience. And I was also going to reflect on my time with, I was doing my PhD and, doing some field work in the Barkentine too as well, because it's located in East London. And I just remember when I was, just sort of hanging out, as I do as an anthropologist, this woman had come in for postnatal care, and she just kind of like also hung out herself. She just sort of sat and just hung out for like an hour, fed her baby, just, and then sort of just like went on with her day. And I think it was sort of making me think about, the ownership of space and how important that is. And particularly when you were talking, Jennie, about, this toxicity, these pop-up, toxic environments, and how part of it, really struck me was like, who is occupying that space? And, you're talking about them being othered. And I was just thinking, when people when both, the people who are accessing care and the families and, the service providers and, the clinicians have ownership of that space, jointly together, no one is other within that space. So that's just sort of my response to that. So yeah, but also Jennie, thank you so much. It's just been fantastic to hear about your work too as well.
Thank you, Cassandra. We have a question from Jeff, and the question, if it's all right, I'll read it, and some of our previous speakers, feel free to answer. So Jeff says, everyone is talking about changing the system or building community and making life better. But I've heard people criticize midwives in the US for being associated with Donald Trump. QAnon and other conspiracy theories, is there a lie there, or how do we deal with structural issues? Jeff, I don't know if you're still in the room. Feel free to turn on your mic and elaborate a little bit, and if you don't mind, and if anyone wants to comment on the question, please feel free.
Yeah, thank you for reading the question. I've seen for whatever 15 years or more now that I've been studying midwifery and midwifery services in the US, UK, and Europe, that there is I see midwifery and midwife communities as a source of change for the good, change for more freedom, change for directing our lives, and bringing about better communities for infants and women and for all people. And when I talk about this, sometimes academics are not nice, like midwives get attacked for saying these sorts of things, because the midwives are associated with these sort of very conservative movements in the US. And I've not experienced any of that myself, but most of my knowledge of midwives is actually with midwives in the UK and Europe. So I don't know if I'm missing something in the US context. I thought maybe Jennie might know a little bit given her place in Florida, but I was curious about this. This is the third midwifery conference I've been to, and the theme is always the same, right? That we need to change, and that if we do change, the world's going to be better. So I'm just wondering, what's the source there? What's the belief that's driving us? And so I wanted to kind of encourage this kind of conversation with all the speakers today, because it was so important or at least I thought it was so important. Maybe I'm just, listening to everyone with my own ears. But I thought that was important to kind of listen to and reflect upon. Thank you.
Thank you. I think when we talk about, we could solve the world's problems and save lives and all this marvelous stuff, it's because, we as midwives have maybe access historically since millennia really to that miracle life beginning, right? Like being part of that, it immediately sort of transfers all this amazing gravitas to what it is we do, and power even to what we do. And of course, as humans, we all want to see that our humanity shows in our work. Midwifery gives us so much access to that, right? Like, unfortunately for the medical systems and these other structures that have shown up, they haven't. There's not a doctor who didn't start out wanting to do some great work in the world, but inside of the structure that the doctors must work, they're not going to get that done. God bless them, they're just not, right? So with the Trump thing and the thing in America, and that's why I was stressing through my presentation, the race of the person, the socioeconomic status of the person, all of those things that have America just completely in its own, conundrum. The country was started off wrong and we're still rolling in the wrong directions, even all these centuries later. We've got, look, just Roe versus Wade. I don't even want to start that trail, but look, these are the things that are showing us that politically, and which is why I keep stressing it's about power, that has the impact of being able to thwart or support your best well-being. When there's a constitution that says everybody has the right to pursuit of happiness and all the rest of it, then that's the constitution. But in actuality, that's not what's happening and not what has happened for a very long time. Midwifery, when it was the thriving and the only way for maternity care to be delivered to the American and the native folk, it was always done with the centralized approach to the care was midwifery care, home-based, obviously, and managed by midwives. When obstetricians came in, they started in the early 20th century in the United States. And when you were talking earlier on in the conference about the tools and the mechanization and all these things that have turned the industrialization of midwifery, at least in Europe and the rest of the world. In the States, it started when they got to use those tools. That's when they developed twilight sleep in the early 1920s, started knocking women out with ether, tying them to the bed, putting up the lithotomy, cutting their piece and dragging a mid-forceps baby out. That was how obstetrics was born in the United States. And the power of that was that then they had to move everyone in the hospital environment and make sure that that was considered to be the safe and normal way. That eradicated midwifery. There was a purposeful legal attempt, and rules and laws, policies were made, and they were eradicated on purpose by mid-20th century. The home birth midwives, mostly midwives of color, African American, Native American, indigenous midwives, immigrant midwives, gone, removed. The midwifery re-emerged in the, in the hippie era in the 70s. And so, what you have when you talk about midwives in relationship to Trump and to those types of politics, that's only because majority of midwives still in America are white. 5% people of color in midwifery, 5%. So these things do have a relationship, not to say that all white people are Trump supporters, but where there are Trump supporters and they are in midwifery too, and they have more power to be vocal and to be sending messages across the pond and wherever else, that's because politics, okay? So we as midwives have our work cut out, because all of us, when we, just like the physicians, when we go back to the original reason we were called to this profession in the first place, is because we care about the humanity of mother, baby, of life being sacred and coming forth, and being a part of supporting that, and only that. That's the only agenda midwives have. With woman, finish, right? So we've got a bit of a way to go now because other things that keep playing in, but the reason why these structures are maintained is because of capitalism, because of the medical and industrial complex, because of the power dynamic that is women's bodies, and sadly, women of color bodies even more so. The commodity has always been producing babies, workforce, labor, you name it. Capitalism, it goes together. And we export that around the rest of the entire world. That's what we do. I don't want to get too political, Joe, and I appreciate the question because it's deep. And we have to dig deep, Jeff, sorry, not Joe, if we have to, really to dismantle this and move forward. We do have to have these conversations.
Your answer. I'm just aware of time, and I know it's been a long day for everyone. There were 2 hands raised, and if you could, if we could just make this our kind of closing questions, reflections. I think Claire and then Rodante, if you both want to say your questions one after the other, and we'll open up to our speakers to make a comment, and then we'll, I'm sure we can go on the app of people who are on the here for the summer school. Feel free to continue the conversation on Discord. Our speakers are invited, I think, as well to participate. So please, Claire and Rodante, if you want to ask your questions, we'll open up to Jenny, Lucia, and Cassandra.
I didn't have a question. I had a comment to Jeff's point, so it's probably better taken elsewhere because it could be long.
Sure?
So let me more questions.
Are you sure? Okay. Rodante?
I also had a comment about this discussion, which I think is a very important one to have, but same as Claire, I think it's better for a later time, and we will have enough time this week. But now I'm talking, I just wanted to take the opportunity to thank Jennie Joseph for your amazing, amazing lecture, and I think we're all blown away by it. So thank you so much for your contribution today.
Thank you so much for having me. It's such a pleasure.
Okay, well, thank you. That leaves us to close then. Thank you so much for everyone for joining us for the day. We've had some really interesting conversations. I want to say thank you to all of our speakers today, to Dr. Dana Ann Davis, to Dr. Natalie Valdez, who really took the time to pre-record her lecture. So please take the time to go back and listen to her lecture. And a big thank you, of course, to Jennie Joseph and to Dr. Lucia Roca Anacho and Dr. Cassandra Yule. Thank you so much. And thank you to City University and the team for the Center for Maternal and Child Health Research and all of your support in helping us host this webinar today. And a big thank you to Rodante and the Critical Midwifery Collective and the Summerschool. Thank you so much. And let's continue this conversation and connect. And thank you so much and enjoy the rest of your day.
Thank you, Anna, for being an amazing host.
Thank you,
That's an
Anna.
honor.
Wonderful job.
Thank you, everyone.
Big hug.
All right, thanks everyone. Until tomorrow. Bye.